Thank you, Chairman. Many thanks for inviting me to this wonderful meeting. My presentation will be focused on sequential correction using multi-rods for lumbar sacral deformity with type C coronal imbalance. First of all, look at the 2C patients on your both. They have a similar curve pattern. It's a kyphoscoliosis, the degenerative scoliosis. And we did the same procedure. On the left side, we did T12 PSO. On the right side, L1 PSO. However, on the left side patient with 7 years follow-up, patient goes very well. And on your right side, patient immediately after surgery, the patient developed with coronal imbalance. So the question why two similar patients with the same surgical strategy, but the clinical results are quite different. First of all, I'd like to introduce to you our classification regarding coronal imbalance pattern in adult scoliosis. We classify imbalance in coronal imbalance into 3 types. In type A means no important imbalance. In type B means a patient has trunk shifts to the concave side. In the type C means trunk shifting to the convex side. So this is a very important why. So, and we approach the validation study in US performed by Schwab team, and they have a similar observation. They found that at their series, nearly 28% of patients degenerative sclerosis they present with a type C classification. So type C patients means trunk shifts to the convex side, not concave side, often seen in 2 situations. First is a degenerative scoliosis with a fractional lumbar sacral curve, like this patient. It's a type C, shifting to the convex side. So degenerative sclerosis with a fractional lumbar sacral curve, very rigid. And the second situation is primary lumbar sacral curve, often seen in congenital scoliosis, particularly in L5-S1 hemivertebrae, like in this patient. This patient is type C, so the patient has S1 hemivertebrae. So these are 2 situations. So what's important is to find the driver of this type C coronal imbalance. The X-ray film, the radiographic feature of the type C is L5 tilting and the trunk shifting to the convex side in a very rigid lumbar sacral curve. So these 2 patients, they have a large fractional curve. So why type C, not type A, type B? Because in type C, the patient has a large lumbar sacral fractional curve. So look at this patient. The main curve only 41 degrees, but the fractional curve on already 36 degrees. And by contrast, in type B, the fractional curve is quite small. So in this patient, only 13 degrees. So when you have a big lumbar sacral curve, very rigid, quite often the patient presents with type C curve. So for the type C patients, the traditional way is a lumbar apex osteotomy and with a pelvic fixation, like this patient. Okay, we did L2 PSO and the fixation T11 to pelvis. And recently, Lenke presented a stick stance technique for type C. So that means he used supplemental rod supporting spine and with instrumentation extended to the pelvis. And we find our own case, which is very similar to his case, and you will see what we did for this. So we found the type C patients are predisposed to maintain the posterior imbalance. Now look at this patient; it's a type C. So after surgery, the patient this imbalance persists. Even even in a 2-year follow up, or sometimes persistent corneal imbalance. So this is a type C. You can see immediately after surgery, the patient has an imbalance to the convex side. With time, with a follow up, a little bit better, but the corneal imbalance persists. Okay. And here's another case, adult scoliosis, but it's an S1 hemivertebrae, and the patient was operated on in another hospital. And after surgery, the corneal imbalance to the convex side persists, and we did the revision surgery for this patient. So for type B, that means trunk shift to the concave side. Why not? Why imbalance doesn't happen in this patient? Because you can see the driver of imbalance in such patient is not a fractional curve; it's a main curve. So focus your treatment on the main curve. So to identify driver of the imbalance is very important. So look at this patient type B. We did osteotomy here. Here at the apex of the main curve, after surgery, you can see the imbalance in cranial plane is well maintained. Here's another type B, imbalance to the concave side. So you can do osteotomy at the apex of the main curve. You don't have to do whatever at the distal level or the distal level. So immediately after surgery, 2 years of follow-up, the balance in the cranial plane is well maintained. So we found in the literature there are many risk factors for postoperative imbalance, such as UIV too high, etc. We found preoperative cranial imbalance pattern it's a neglected factor. So it's quite important to identify the type A or type B or type C imbalance in cranial plane. And look at this patient. The patient is 52 years old. It's relatively young degenerative scoliosis. She was operated on in another hospital. After surgery, you can see 2 months post-operatively, the patient is unhappy and extremely unhappy because of severe imbalance in cranial plane. And many Chinese surgeons say the reason is you overcorrect the main curve. I say no, it's not related to the overcorrection of the main curve. The essential problem in this patient is fail to level L4, L5, not overcorrection. So the fail to level L4, L5 contributes to this complication. So what I did is to level L4, L5. So we did 360 degrees osteotomy, and I will show the surgery after. So how to prevent corneal imbalance for the type C? Not stop distally. It is a fixed tilting vertebrae, and you must do distal PSO, not at the apex of main curve, and the lumbosacral 300 degrees TLIF. For traditional TLIF technique, is you do TLIF by one side, but for type C patient, if you do TLIF, quite often you should do bilateral. So that means 360 degrees TLIF. If there is hemivertebral, you must remove it complete. Then, in case of the necessary, you can do apex osteotomy of the main curve, quite often PSO. So we call it the packaging solution. We found a packaging solution. What's the meaning of the packaging solution? It's a sequential crushing using multi-rod. So how we do it? First, we develop a dual head screw head screw with a company. This is a dual head screw or double head screw. This is specific designed implants used for such patient. So we put the dual head screw somewhere, and we do osteotomy at the distal level. Quite often L5. And if L4, L5 are not tilted very much, you don't have to do osteotomy at L5. You can do 3-level TLIF, 360 degrees TLIF. Okay? Then level L4, L5 with one short rod. Very important. Not focused on the apex of the main curve, just distal level. And level L4, L5. Then you come to the main curve. If necessary, you can do second osteotomy at the apex of the main curve. Then you use a long rod to connect distal instrumentation with proximal instrumentation. So this is type C patients. You can see L4 tilted. If you ignore the L4 tilted, you focus your correction on the main curve. Certainly, after surgery, the patient will present with important cranial imbalance. So in this patient, the essential issue of the surgery is level L4 and L5. So what we did is L5 osteotomy, and L4 is level. So you can see after surgery. We presented this as a case discussion in an international conference. Many surgeons, they say you should stop instrumentation to the pathological level. So if you are able to level L4, L5, you don't have to go to up very high to the thoracical spine. This is a degenerative scoliosis. She was operated on in another hospital. After surgery, you can see important imbalance. The patient presented with type C imbalance. So if you don't focus your treatment on the distal level, so after surgery you can see. So again, the essential issue of the surgery is level L4. So I did a revision surgery. I did L4 osteotomy, level L4, then cranial balance is corrected. And here's another patient, type C, you can see. So focus your instrumentation on this level, so on the distal level. And we did L5 osteotomy, level L4, and after surgery. So you are not able to balance this patient by long instrumentation. Even you do instrumentation from T2 to pelvis, you are not able to balance the spine. And L5, sometimes widget L5, structural widget L5 contributes to lumbosacral curve. Look at this patient. His degenerative scoliosis is long-standing, and L5 is a widget, and L4 tilted. So do osteotomy at L5, not only the apex of the main curve. So in this patient, we did 2-level osteotomy, L5 osteotomy to level L4, L5 for the cranial imbalance, to correct the imbalance in the cranial plane, and osteotomy to the apex of the main curve to correct the kyphosis. So after surgery, you can see both. Okay. And we have, and here's another patient. Sometimes the patient presented with L4, L5 subluxation. So in this situation for the type C, you can do multi-level TLIF, 360 degrees. So you can see after surgery with follow-up. And we participated in an international multi-center study regarding the degenerative scoliosis. So this is type C. You can see L2, L3 tilt. So what we do is multi-level TLIF, and horizontalize L3. And after surgery. Here is another case, very similar case, type C with 2 years follow-up. And here is another case, kyphotic, type C, and after surgery. So this is a patient. The driver of the imbalance in cranial plane in this patient is S1 hemivertebrae. So remove it completely in the level L4. Level L4, you can see that you don't have to do long instrumentation. And we do have some rod breakage with multi-rod. And with traditional technique, 2 rods, we have at least 15% rod breakage at 2 years follow-up. So now we routinely use multi-rod in severe degenerative scoliosis, particularly for type C. But we do have some rod breakage. So some interesting message to avoid iatrogenic coronal imbalance. First, identify the imbalance pattern at first, particularly for type C, and very careful with type C patients. And for type C patients, correction of the fractional curve distally more important than main curve. Level L4, L5 by distal osteotomy is essential portion of the surgery. Thank you.